pleasure now to introduce you to my friend and colleague, Dr. Michael Krause, who is the chair of the Let's Talk Overdose conference and also chair of our next keynote session. Dr. Krause is the BC Leadership Chair of Addiction Research and head of the Addictions and Concurrent Disorders group at the UBC. His research explores the relationship between early life trauma, substance use disorders, and other mental illnesses. So it's my great pleasure to have Dr. Krause here. The floor is yours.
Thank you very much. Will use a little bit of the 2 minutes in between the keynote and now. The issue we are addressing is of high complexity, and high complexity needs especially a good synergy, which is bringing together the different expertises, the different areas and perspectives. And I think with this conference, as with others, we are able to do that. And especially welcoming also people joining from other countries, because there are lots of things we can learn from other countries and their experiences. And there is also a lot of things we can share and we need to share, even if the experiences are not that pleasant as the numbers already quoted today. I want to especially underline the effort to bring more people with lived experience into the conversation. We have to build on these experiences to be better able to address that. Somebody who is doing that to a very significant degree in his clinical work and in his research and advocacy is Dr. Nick Matthew. He is the medical director of the Tertiary Care Center, Redfish Healing Center, and also medical director of Heartwood Center for Women, Ashnola Crossing, and other centers. He is a strong advocate, and he is also not shying away from addressing new developments and experiences. But we need this openness, we need transparency, and we need especially good examples. And Redfish is certainly one of the crown jewels in BC in terms of our healthcare response. So it's my great pleasure to invite now Nick to the microphone, and we're really looking forward to your keynote. Welcome, and thank you for joining us.
Thank you for the introduction, Michael. So I have a video in this presentation, and I'm hoping that you guys will be able to hear the video. It might be a little bit quiet, so once we get to the video, if you guys can turn up the sound. So I'm going to be speaking about the rise of high-potency synthetic substance use in the Canadian healthcare system. So my main conflict of interest is I'm going to be speaking about the Redfish Healing Center. I'm the medical director there. I don't have any other financial interest, arrangement, or affiliation to disclose. For the objectives of the talk, I'm hoping that we can appreciate the psychiatric sequelae of high-potency synthetic substance use, as well as the vulnerability of patients with psychiatric disorders to high-potency substances, outline the treatment options for concurrent disorders, and describe common factors that may affect access to mental health services for people who use high-potency synthetic substances. So I want to talk about the comparison in overdoses between different places internationally. And so if you look internationally, the #1 place for overdoses, and these were numbers from 2020, and the reason why I use that is so we can compare all of these different countries. The #1 place was the US, and this is the number of overdoses per million people. And as you can see in the US, they had 277 people per million overdose and pass away that year. And in Canada, writ large, it was 171. Where does BC fall among this? BC has 344 overdoses per million. So it's one of the highest places in the world in terms of overdoses. So I want to bring this back to a clinical case of someone that I saw at Youth Forensics. So I'm going to use a pseudonym. John Doe's father left the household when John Doe was young. He experienced racism in school due to his skin color. He found a sense of belonging in a group of friends that used cannabis. He started using cannabis in elementary school and started to skip school to use with friends. In high school, he was transferred to an alternative school but dropped out shortly thereafter. He started using opioids with hydromorphone that he bought from the street. Due to his drug use and theft at home, he was asked to leave and move to the downtown east side. To stay awake on the streets, he began using crystal meth. Roughly 1 year prior to the index offense, he began to experience psychosis with paranoia, visual hallucinations, and heard voices with his auditory hallucinations. So this is an aside about the downtown east side. So a report from the BBC called it one of the places with the worst drug problems in North America. There was the hotel study that was done, and they looked at the comorbidities of folks in the downtown east side. And what they found was that 95% of folks had a substance use disorder. About half had psychosis, and about 45% had a diagnosable neurological disorder that could be found on MRI. So getting back to our case, on the day of the index offense, John Doe was using fentanyl and crystal meth. John Doe heard voices that the victim was going to rob him. As a result, John Doe punched the victim. The victim grabbed John Doe, who is now afraid for his life. John Doe then pulled out his knife and stabbed the victim in the neck. John Doe felt remorse after the event when he was no longer intoxicated and psychotic. So I want to highlight, with the rise of potent synthetic substances, one of the things that we're seeing is random stranger violence. And I'll illustrate the connection later in the talk. So how did we get here? How did we get to the point that we are today? So I want to start with Arthur Sackler. So Arthur Sackler was a NYU psychiatrist in his 20s, and in his 30s he became a Madison Avenue ad agent. And he started the terramycin campaign in 1951. So terramycin was an antifungal agent. And what he did was he invented the direct-to-physician advertising. So he created materials for physicians, and he had pharmaceutical reps go directly to physicians and market the drugs to them. And he made so much money from this campaign, him and his brothers, that they bought a pharmaceutical company called Purdue Pharmaceuticals. Well, fast forward to 1959. Paul Janssen was a pharmacologist, and he started Janssen Pharmaceuticals. And there was new technology called magnetic resonance that allowed him to visualize the morphine molecule. And he figured out a way to create a molecule that would fit the mu opioid receptor more effectively. It crossed the blood-brain barrier more effectively, and it wasn't metabolized into anything else. It was 50 to 100 times more potent than morphine, and it wore off sooner. And so this was actually an advantage. It was sedating for a shorter period of time. And they were able to do conscious sedation where people were awake and could have abdominal surgery. It was an amazing thing to see at the time. So, I mean, it was a very useful molecule. In 1968, he published dozens of analogs to this molecule in a journal called The Drugs Affecting the Central Nervous System. And there he invented other analogs of fentanyl, including sufentanil and carfentanil, stuff that we're seeing on the street now. Well, fast forward to 1980. There was a graduate student named Jane Porter and a physician named Herschel Jick out of Massachusetts General Hospital. And this was the Harvard Hospital. And Herschel Jick had thousands of patient cases. And he looked at the folks that were prescribed analgesic medication in the form of opioids. And what he found was that less than 1% of the people that were prescribed opioids developed an addiction. Now, this was later lionized in Scientific American as an extensive study and Time magazine as a landmark study, but it wasn't actually a study at all. It was a 5-line letter to the editor. Now, one of the serious issues with this letter was that they didn't look at people after they left the hospital. They only saw if people became addicted while they were in hospital. Well, fast forward to 1996. So we look at the American Pain Society president, Dr. James Campbell, and what he said was at the address to the American Pain Society, if pain were assessed with the same zeal as other vital signs, it would have a much better chance of being treated properly. We need to train doctors and nurses to treat pain as a vital sign. Looking back, I mean, this seems a little spurious because a vital sign is something objective, whereas pain is the subjective experience of an individual. So it couldn't really be a vital sign. But what I want to highlight here is that there's a lot of good intentions that people have and a lot of bad, horrific, unintended consequences that can arise from these good intentions. Also in 1996, OxyContin was released by Purdue Pharmaceuticals using the same direct-to-physician advertising invented by Arthur Sackler. And when they went to physicians, pharmaceutical reps would cite the 5-line letter to the editor by Porter and Jick that said less than 1% of people prescribed opioids would become addicted. Now, that's one of the most highly cited letters of all time. Last time I checked, it was over 1,300 citations, according to Google Scholar. So what happened? This is looking at Ontario, and what you're going to see is a red line that peaks around 2010. And that was the deaths that occurred in Ontario due to oxycodone. Now, I want you guys to look on the far right. On the far right, there's a darker blue line. That darker blue line is the deaths that came from fentanyl that was created by Paul Janssen from Janssen Pharmaceuticals. So why do we have to worry about psychiatric patients when we think about overdoses? Well, one thing is that there's an overprescribing of opioids to folks with mental illness. So what they found was that the 16% of Americans who have mental disorders receive over half of all opioids prescribed in the US. So this was from 2017, and it was the deaths from the coroner's report from 2017 that year. And what they found was that 52% of the people who passed away that year had a reported or suspected mental illness. So the big thing that I want you guys to take away is that for psychiatric patients, they are especially vulnerable to opioid use disorder and to overdose, and that concurrent disorders, when we look at the opioid crisis, is the rule. It's not the exception. I'm going to switch gears and I'm going to talk about crystal meth. So how did this get invented? So there was the ephedra plant, and from the ephedra plant, they could isolate a molecule called ephedrine, and they could turn this molecule into amphetamine. And the first people that were able to do this were Japanese scientists. And they named the drug Hirapon, which means fatigue, fly away. And this was actually used by soldiers and kamikaze pilots during World War II. Temmler, a pharmaceutical company in Germany during the Third Reich, marketed it as Pervitin, and they gave it to soldiers during World War II during the Blitzkrieg. The ephedra method was forgotten, and biker gangs created another method. The problem with the biker method was that the products that they made were explosive and they made a horrendous smell. So when they were making meth, uh, they would have to do it out in the wilderness where nobody was around, and still these labs would end up blowing up. However, the ephedrine method was rediscovered in the early 1980s, and as a result, it was used to make crystal meth. And because of this, ephedra was banned in the US in 2004, and sales were restricted in 2006 in Canada. So what happened after 2006? Mexican cartels had rediscovered and perfected the phenyl-2-propanone method. Now, why is this significant? They were able to make phenyl-2-propanone from very cheap substances that were easily obtained, as well as methylamine. And when they combined these two, they were able to make methamphetamine. But what was especially potent about the phenyl-2-propanone method was that they were able to be stereoselective with the meth that they made. So there were two kinds of meth. One is L-methamphetamine, which is a nasal decongestant. It's not psychoactive. It doesn't cross the blood-brain barrier. And then there was D-methamphetamine. Now, D-methamphetamine crosses the blood-brain barrier, and it's highly potent. So the meth that we're having now is more pure D-methamphetamine. This is the phenyl-2-propanone method. Now, this is more psychoactive than crystal meth that was found in the past. So why do we have to worry about this? So if you look at stimulants and you're prescribing stimulants for ADHD, it's pretty unlikely that someone develops psychosis. 1 in 660 people will develop psychosis, so it's a small amount. However, when we're looking about an amphetamine use disorder and people using crystal meth, if you take the entire population of people who use crystal meth, 40% will become psychotic. Now, what's interesting is this actually increases with severity. So an older study looked at amphetamine abuse versus mild, moderate, severe amphetamine dependence. And once you got to severe amphetamine dependence, this was the old DSM-4 term, 100% of the folks would experience psychosis. Why is this something that we have to worry about? Well, psychosis is a neurotoxic event. So what does that mean? When you first start using meth, you won't become psychotic. Then you become psychotic during the intoxication phase. Then as you keep using, you become psychotic into the withdrawal phase. And then it extends into periods of sobriety. As a result, there's a kindling effect that occurs when people use crystal meth. And one of the issues is antipsychotics will not prevent someone from becoming psychotic. So anyone who's worked in a psych ER will know this. You'll have patients who have a depot antipsychotic medication on board. They use crystal meth, they become psychotic, and then they show up at the psych ER. The benefit of the antipsychotic medication is that it helps prevent this kindling effect. Now, this was data found from animal studies, so it's not entirely sure if this happens with human beings, but this seems to be the benefit. Now, there is criticism of the DSM criteria when they look at substance-induced psychosis. Now, why is this? Well, with the DSM criteria, one thing that they say is that if a psychosis is less than 1 month long, then it's likely substance-induced, and if it's longer than that, then it's likely an intrinsic organic illness. However, this was back in the DSM-3. They knew that cocaine and amphetamine psychosis could last up to a year. And they know that 27% of methamphetamine users with no evidence of schizophrenia had psychotic symptoms last longer than a month. And then when you look at things like cannabis-induced psychosis, Shaw and all had a study where they looked at folks who had cannabis-induced psychosis. And what they found was that 80% of the people who had cannabis-induced psychosis had psychosis lasting longer than a month. So what we're having is more psychoactive meth out there. It's one of the more commonly used substances. So when they looked at folks with who had overdosed and died in the past year, about 40% had a methamphetamine in their system. So there's a greater uptake of this. It's more potent, and you're more likely to become psychotic. Now, with psychosis, people with psychosis are more likely to be victims of violence than perpetrate violence, but it is also a risk factor for violence. So if someone has psychosis, there is a 3 to 4-fold increase in risk of psychosis of violence in those folks. So in the general population, the risk of violence is about 3%. In people with psychosis, it's about 9 to 12%. So with random stranger attacks, this is something that we're seeing on the streets. There's an increase in random stranger attacks. There's an increase in people using high-potency phenyl-2-propanone crystal meth. But then there's also a conversion of diagnosis to schizophrenia eventually. So this was a Finnish study, and it looked at people with different substances who had first episode psychosis, and they followed them for 8 years, and they looked at what percentage of them would eventually be diagnosed with schizophrenia. And what they found was that 30% of people with an amphetamine-induced psychosis eventually were diagnosed with schizophrenia. So I want to talk about the Redfish Healing Center and what we're doing there. Now, the first question that I often get is, why is it called Redfish? And so I want to do my land acknowledgement at this part of the talk. And so the Redfish Healing Center is located on the unceded traditional and ancestral territory of the Coquitlam First Nations. So the word Coquitlam means red fish up the river. So we were gifted the name Redfish Healing Center by the Coquitlam people. Now, Councillor George Chaffee said, calling it Redfish means the Coquitlam people are still here, and the name itself stands for healing. So we're trying our best to partner with the Coquitlam First Nation and be involved in reconciliation with them. So what is it? Well, we opened on October 12th, 2021, and it's a 105-bed facility. There's 7 units, and it is a designated mental health facility. So what is the population that we serve at Redfish? So what we're doing is we're looking at people with the most severe mental illness and severe substance use disorders. It's a provincial program. So we're under the Provincial Health Services Authority. So there's 5 regional health authorities in British Columbia. The 5 regional health authorities will find folks in their home health authority who have not found success in the addiction and psychiatric treatments available in their home health authority, and then they'll refer those folks to Redfish. If those guys, if the folks being referred to Redfish meet our admission criteria, so do they have a severe mental illness? Do they have a severe substance use disorder? Then we accept them onto the admission to Redfish, but the home health authority holds the wait list. So the home health authority prioritizes which patients are the next ones that go to Redfish. So usually the home health authority looks at the folks who are taking up the most resources in the home health authority or who are in the most need, and they're the ones that take the next bed. So there's a number of designated beds for each health authority within Redfish, and it's distributed by population. We never have an empty bed at Redfish. So if one health authority is underutilizing their beds, then other health authorities can use their beds. So this population has a history of homelessness, victimization, domestic violence, poverty, and trauma. When we look at the people who are certified, about 60% of the people at Redfish are certified under that Mental Health Act, and 40% come there voluntarily. So a lot of the voluntary patients might be on extended leave and are not recalled to Redfish. They might be there voluntarily. So we have different domains of treatment and programming within Redfish. And so this slide covers a lot of the groups that we have at Redfish. So for instance, we have a meaningful life domain. So we want to build up employability skills. So there's opportunities for people to do things like volunteer work. There's also skills development. We have the Redfish Healing Room, or sorry, the Hummingbird Healing Room. And this is a room where they have negative pressure so we can do smudging indoors all year. So we have Indigenous care coordinators that provide Indigenous medicine and Indigenous care to anybody who wants it at Redfish. When we look at our population at Redfish, 50% of the people coming to Redfish self-identify as Indigenous, and the highest proportion comes from Northern Health. We also look at physical wellness. So there was an earlier slide where I showed 52% of the people who overdosed in 2017 had a mental illness. Well, 58% of people have chronic pain. So we have pain management groups, but we also have a pain physician that helps address chronic pain issues and helps optimize it while they're at their center. We also have family physicians and nurse practitioner who can help take care of people's physical health as well. One of the issues is problem behavior. So when we look at the folks that come to Redfish, 70% have a history of violence. So we have things like anger management groups to help people develop skills so that they can manage their anger. We also have contingency management that allows people to encourages people to attend groups and also to remain sober while they're there. So they can get vouchers for prizes that they want, and also they can trade in the vouchers to purchase things at a Value Village that they would like. So when you take away drugs, you can't just leave people with nothing. You have to provide them something of value. Then there's also family and intimacy. So there was a reporter named Johan Hari who actually coined the phrase. He said, the opposite of addiction isn't sobriety. The opposite of addiction is connection. And what we try to do is foster relationships with folks outside of Redfish Healing Center, like family or friends that they can reconnect to, where they can have pro-social relationships. So right from the very beginning, we invite family members or people who are close to the patient and their team, and we start the discharge planning right away when they're in Redfish. We also look at mental wellness. So we have things like cognitive behavioral therapy for depression or psychosis or anxiety. There's a lot of trauma in this group. So we have Seeking Safety, which helps address post-traumatic stress disorder and substance use disorders simultaneously. There's a lot of folks with personality disorders or emotional regulation. So we have dialectical behavioral therapy there. For substance-free living, we have things like smart recovery, and we also have Matrix. And Matrix is one of the few evidence-based treatments for amphetamine use disorder. So this is a really busy slide, and I'll walk you guys through it quickly. So I described the pre-intake. People apply. If they meet our admission criteria, then they get put on the wait list. Then they'll come in. So imagine a person with schizophrenia who is addicted to methamphetamine and is also using fentanyl. They'll come in. They might be floridly psychotic. And initially, in the initial stabilization period, we stabilize people for 4 to 8 weeks. So we try to control their psychosis, and we also try to control their withdrawal symptoms from crystal meth. And we also try to put them on opioid agonist therapy if they're using fentanyl, which more than half of the patients at Redfish are. Then once they've been stabilized acutely, then they go to the treatment and recovery portion, which is 12 to 16 weeks. So the average length of stay at Redfish is 6 months long. People can stay up to 9 months. And we will deal with things like psychosis or addiction or physical health. So for instance, 30% of people with schizophrenia will not respond to medications. So we provide things like metacognition for psychosis, where people can rethink the way that they interact with their own psychosis and thoughts. Throughout the entire time, they're connected to their home health authority, and we make a discharge planning, and we try to find housing. So about 70% of the folks who leave Redfish will have housing. There's also the Coast Rehabilitation Recovery Program, where people can stay an extra 12 months as a step down from Redfish and Heartwood. When we look at the outcomes, we're looking at early remission according to the DSM-5, which is 3 months of abstinence. We're looking at the addiction severity index, and we're looking for a reduction of score of 80%. And from mental health systems, we're looking at the Health and Nations outcome scores, and we're looking for a reduction of score. So why is our program this long? Well, this was a study that looked at folks who came into treatment centers, and what they found was that 39% of people had psychiatric symptoms. But within 1 month of sobriety, this dropped to 3%. So there was a 13-fold decrease. So one of the benefits of Redfish and the length of stay there is that we can help differentiate what symptoms are intrinsic organic psychiatric disorders and which symptoms are substance induced. We also treat mental health and psychiatric symptoms concurrently. So this was a study out of Ontario, and what it did was it looked at folks who were in methadone clinics, and they looked to see if there was a benefit of adding psychiatric treatment to opioid agonist therapy like methadone, Suboxone. And what they found was that when you added psychiatric treatment, you decreased hospitalizations in both Northern and Southern Ontario, you decreased ER visits, and in Southern Ontario, you decreased all-cause mortality. So the things that were killing these patients happened less when you added psychiatric treatment. There's a lot of people on this talk, so I just want to put this out there, and this is something that we do at Redfish, is contingency management. Out of all of the interventions, more than any pharmacological agent, more than anything, the thing with the most effectiveness for amphetamine use disorder is contingency management. And this is based on operant conditioning. So when people provide a negative urine drug screen or show up to treatment, they're given vouchers, and the vouchers can be traded in for a larger prize, or they can be traded in for stuff to buy. And so what it does is it rewards people for engaging in treatment and remaining sober. And what they found was that even when you stopped providing contingency management, there was a benefit in terms of abstinence 1 year following contingency management. So when we're looking at psychosis, how long does it take to treat psychosis? Well, one thing that you look at is hallucinations, and these are all numbers from first episode psychosis. For hallucinations, it's 27 days. For delusions, it's 76 days. So the time to treat psychosis is longer than hours or days. I mean, this is months that it takes, weeks to months. The other thing to look at is protracted withdrawal. So what is protracted withdrawal? I get a bit tangential and I'll bring it back to the subject at hand. So protracted withdrawal is what occurs when you stimulate your brain with dopamine to levels not found in nature. So imagine astronauts going up into space. They lose bone and muscle mass. Why? Because your body's saying, why do I need to spend all this energy making bone and muscle if I don't have all this gravity to fight against? In the same way, when you stimulate your reward center, your nucleus accumbens to levels not found in nature, you lose dopamine receptors. And as a result, you're going to have difficulty experiencing pleasure in normal activities. And so one of the most common things I hear from my patients is, Doc, I stopped using. Why don't I feel better? So acute withdrawal, depending on the substance, can last 7 to 14 days. With protracted withdrawal, the symptoms are worse 3 to 6 months into recovery. So there's anhedonia, inability to experience pleasure. Then there's difficulties with concentration. Why? Because your orbitofrontal cortex also has dopamine receptors. And you can also have issues with sleep up to 18 months out. So when do you start getting recovery? About 8 to 10 months of rigorous uninterrupted treatment. Now, to return to your pre-morbid level of functioning, it takes 18 months to 2 years. So these problems take months to years to solve. This isn't something that days or weeks or a 30-day program is going to help people with. So our program is up to 9 months. So that's why we have that sweet spot of 9 months between the 8 to 10 months of rigorous uninterrupted treatment. So what are our outcomes? So when we look at psychiatric symptoms and we look at decrease in HONA scores, we're seeing 95% of our patients are improving. Are they fully recovered from schizophrenia? No. But they are improving to the point that they can now leave Redfish and go into the community in a much safer manner. What about for uh, addiction? So when we look at an 80% reduction in HONA score, for alcohol, we see a 92% of our patients are have that improvement. And when we look at other substances writ large, it's about 76%. So we are looking at more long-term outcomes. This is the ROAR Canada study that my friend and colleague Christian Schutz is doing. And we're looking at population data in terms of hospitalizations, ER visits, overdoses, primary care visits, medication, arrests, and incarcerations. And we're looking at 2 years before and 2 years after. We're doing a chart review within their time at Redfish, looking at their mental health, substance use, treatment, aggression, victimization. And we're looking at during their time in treatment and 6 months follow-up. And we're also looking at questionnaires and tests during treatment, looking at substance use, mental health, cognition, physical health, and forensic issues. And so this is all happening while they're at Redfish. So we have sent our protocol paper for publication in February, and then we're going to start answering some of these questions about the long-term benefits of Redfish. So it's only been open for a couple of years, so and it takes time to do this research. So that's sort of the delay that's occurring, but we are actively studying the outcomes. So one thing that I want to direct everyone at is that when we look at in terms of psychiatry, one of our biggest focuses is suicides. And we don't tend to look at overdoses as much. And I'm not putting up this slide to minimize the impact of suicide deaths. Suicides are very important. But also when we have psychiatric patients, we should also look at something that's more likely to kill them, and that's overdose deaths. If you look, there are almost double or more than double the number of overdoses than suicide deaths. So I wanted to end my portion of the talk with something a little bit more positive. So on the far left, that's the brain image of someone who's a healthy control, so someone who doesn't use drugs. And what we're looking at is dopaminergic activity, the thing that I was talking about earlier in the study. And the more red it is, the more dopaminergic activity you find. So the stuff that I was talking about with recovery, is this something that's just my opinion? No, this is something that you can actually visualize on brain imaging. So the slide in the middle is a person 1 month into abstinence. And as you can see, there's lower dopaminergic activity. And the slide on the right, the picture on the right, is the brain of someone 14 months into abstinence. And as you can see, they've reached near pre-morbid level of functioning. So this isn't something that's just my opinion, that this is something that can be visualized. So the main point I want to get across is that recovery is possible, but it takes time, and you can optimize it concurring treating mental health and substance use disorders concurrently. So in my talks, I like to have the patient voice. And so this was a patient that I used to treat and was in Burnaby Center, now Redfish. And they want to give their opinion of some of the barriers to care that occur and some of the improvements that could occur with the mental health care program.
Hi, my name's Ollie. I'm an addict in recovery. I use he, they pronouns. I was one of Dr. Matthews' patients at Burnaby Center for Mental Health and Addictions before it became Redfish Healing Center. I'd like to say a huge thanks to him for having me here today. I feel really privileged to have this opportunity, and I hope I can do it justice. That being said, I'd like to acknowledge that there's no way I can touch on everything I'd like to in 10 minutes. This is a super simplified version of my story, and it's important to keep in mind that every case is so nuanced and so unique to every individual. I know probably more addicts than non-addicts, and I don't know a single one that doesn't have some kind of other mental health concern. So I came from what looked like a pretty normal middle-class home. I was a dysfunctionally good kid. I say dysfunctionally because no one is that good unless they're scared. I didn't even really know I was scared because I didn't know anything else. I was homeschooled until I was 14, so in a lot of ways I was pretty sheltered. But I started to really struggle around the onset of puberty, and I think that was mostly due to a couple things. One of them being that my parents were addicts in recovery themselves. They had both been clean and sober since before I was born, but when I was about 12, one of them relapsed. I didn't know it until years later, but I did feel a shift at the time, and I just knew that suddenly home was not a nice place to be. I also struggled a lot with puberty itself. I'm transgender, and I had no education around that topic at all. It was a completely foreign subject to me, and I just thought there was something wrong with me. I think puberty is awkward and embarrassing for a lot of kids, but for me, it felt very violating and traumatizing. So, in response to those two things, I coped in a couple ways. One of them was I started to self harm, and I also developed an eating disorder, which is something I still struggle with. And I think those were both ways of punishing myself for whatever was going on at home that I perceived to be my fault, and also a way of coping with gender dysphoria. There was a lot of self-hatred, and I thought that if I didn't eat, then I wouldn't have puberty, basically. So when I was around 14, I started looking for help. I think going to public school was kind of a subconscious way of seeking help. I felt like I didn't want to be at home all the time. And I also thought there would be more people I could talk to about it. And I started talking to school counselors, and they were quite dismissive. They would ask if I was being abused, and I would say no because I thought that that meant being hit or being molested, and I wasn't. So I just always said no. And I also thought that the word abuse sounded like a dirty word, and to use that word would mean to say that my parents are bad people. And I didn't think that then, and I don't think that now. I think they just had their own struggles, and sometimes things got messy. But because it wasn't explained to me in more detail, I didn't know that I was being abused. I wish questions had been asked like, are you afraid of someone you live with? Or does someone you live with break things when they're angry, or make threats, or make you question your sanity, etc., etc.? I don't think a lot of 14-year-olds have a working definition of emotional abuse. But because I was allegedly not being abused and I had no other visible behavioral issues, it kind of just got dropped. And so I continued to struggle with those issues throughout high school. And when I was 16, it was kind of at its worst. So I was a year ahead. I was in my grad year. I was working 3 jobs. I was in competitive sports. And I think that's a lot for anyone, but I was also not eating or sleeping, so I just couldn't keep up. And I started joking that I needed something that was more than caffeine and less than cocaine. I was just joking, but one of my coworkers one day was like, "Oh, I have a pill that's kind of like that." And so I gave it a try, and I didn't think about it as doing drugs. I thought doing drugs meant going to a sketchy house and buying a sketchy bag and trying to get high and party. But I just thought of this as like taking a Tylenol for a headache. It was just something that fixed a problem I had. And so I started doing that, and I also started doing the same thing to go to sleep with things like Benadryl and cough syrup. And it just kind of progressed from there, I guess. When I was 18, I found out that one of my parents was using. I was quite upset about it, and I left home very abruptly and very angrily with very little planning. And things kind of went downhill from there pretty fast. I was using to function. And when you're a kid in high school living at home, it's a lot easier to function than when you're an adult working a full-time job on the streets. I was on and off the streets, but housing was definitely a struggle. And so obviously my using increased to match my demands. There was also a shift in the sense that there was just more substances available, and it was more normalized, and there was a wider variety. And the other thing that changed was I was angry. I felt like I had spent my whole life trying to be this perfect kid, and I had hit a point where I thought I could be a lawyer or a crackhead and it wouldn't make a difference, so why not? So things really just got out of hand quite quickly, and then a kid that was really close to me got murdered, and that really messed me up. And at that point, I kind of just stopped caring. It was kind of, I just went off the deep end. I started using a wider variety of things. I had mostly been using stimulants up until that point, but I started drinking more, experimenting with opiates, and I mean, I always smoked a lot of weed, and I started introducing like benzos and that kind of thing, and the quantities went up as well. So things just got out of hand really fast. And when I was 20, I had just kind of had enough. I just couldn't do it anymore. So that's when I checked myself into detox basically, and then I ended up at Burnaby Center from there. I had a really good experience at Burnaby Center. I was kind of disqualified from a lot of places. One reason for that was I had other mental health diagnoses, and at the time I had also had some psychiatric hospitalizations. So most like normal treatment programs won't take you when you have those issues. The other issue was I was genderqueer. I had not started medically transitioning yet, but I felt wrong going to a women's treatment center, and I felt unsafe going to a men's treatment center. So Burnaby Center was a concurrent disorders facility, and it was co-ed, and it was also a longer program, which I think is really important because a lot of treatment programs are like 30 days and then you're back out there, and like 30 days is barely enough to detox. So in terms of changes I would love to see less exclusionary criteria. I find that there's a lot of gaps in the system in terms of you're too sick for outpatient, but you're not sick enough for hospitalization, so you kind of just get left with nothing, or you can't go to a normal treatment facility because you have this or that diagnosis, but you can't go to a concurrent disorders facility because you don't have enough diagnoses or the right one. I still struggle with that even at almost 3 years clean. I am having a hard time finding a government-funded trauma therapist because of eating disorders, but I can't go to the eating disorder clinic because it's not bad enough, right? I think there also is a lack of wraparound care after treatment. I would love to see someone get out of treatment and get hooked up with a GP, a psychiatrist, a social worker, and a therapist for like a relatively long period of time, because there's so many things that come up after you get clean that are kind of masked by substances, and there isn't really the support in place to take care of that. So that would be amazing to see. It's kind of crazy to see people get out of treatment and not have any follow-up. I'd also love to see more gender inclusive help for substance abuse, because a lot of it is so religiously gendered, and I think that gender exclusive treatment centers do have a place, especially for women who might not feel safe around men, especially if they're in a vulnerable state. But if it's all just male or just female, it kind of leaves queer people out in the cold, because yeah, there's just, you don't really fit in either category, so it just makes it kind of difficult to access help. And yeah, that's kind of what I've got to say. And program length is important as well, because yeah, like I say, 30 days is not enough to deal with a lifetime of troubles and substance abuse and being abused, etc. So that's me, that's my story, and I hope it was helpful. Thanks for having me.
Um, so I'm hoping that the folks who are watching, there's probably some influential people here, but I'm wondering if we can reorient the system and maybe implement some of the things that Ollie was mentioning in terms of wraparound care and follow-up care and concurrent disorders treatment, so that people like Ollie can get the care that they deserve. Happy to take any questions. Thank you.
Thank you. And we have now exactly 9 minutes, with probably half a minute for transition. So I also want to say to everybody who has questions, and there are some already posed, you bring them up also in the following breakout sessions. There is a lot of overlap with different topics. Nick, thank you very much for a very comprehensive and intense ride along several topics, very informative and stimulating. There was one question here. How long are you in Redfish tracking people's well-being, overdose, hospitalization, and so on? And so how much is how big is your reach and connection to the community after several months in Redfish?
Yeah, I mean, so Redfish is an inpatient provincial program, so we don't really have interaction with folks after they've been discharged. We bring the outpatient team in from the onset, and so for things that they need to do in terms of discharge planning and connection to the community, if they need documents, if they need assessments, that those are things that we can do. But it is the outpatient team's primary responsibility to find housing. So the good thing about Redfish is folks can have up to 9 months at Redfish, and then afterwards they can have another 12 months at Coast. So that gives people 21 months to improve the housing situation for the patients that come in. Unfortunately, we can't be experts in housing for the whole province, but 70% of the people that leave Redfish do have housing. Among the other 30%, some of the folks end up at Coast, and other people end up at less than desirable housing situations.
So next question is, what kind of partnerships you have with other social service agencies, and how do you have any ideas how to improve the interaction between the community services, housing services, and something intense like Redfish?
Yeah, I mean, so I think this is one of the issues that we're finding in British Columbia. So I was recently in Switzerland last week, and I saw what they did. And one thing that I think that we've been focusing too much on in British Columbia and in Canada is prescribing medications for people. And what I do think is we need an entire continuity of care. So, for instance, in Switzerland, they would have outreach teams that would go out to places where people use drugs and just form relationships with them. So not for the purpose of getting people into treatment or anything like that, but just to know the individual and to figure out what their problems are and help them with the problems. And some of those people will want to engage in treatment. And so then those folks would be brought into a place where they could have housing, where if they had intense physical problems, those would be managed, or intense psychiatric problems, those could be managed along with their substance use. And as they improve, then they can go, there was an entire continuum of housing where they'd have step down into more and more independent living. Or if they needed inpatient treatment, there would be a fluid, non-siloed way to enter treatment, and there were different hospitalizations for different types of substance concurrent disorders, and then there was discharge back into housing. So there was an entire continuum of care for people, whereas I think there's very siloed thinking in British Columbia, and I think there's an over focus on medication. I think in terms of medication, I think we've likely reached an asymptote of what we can do in terms of benefits. And I think the energy needs to be spent elsewhere in breaking down these silos and forming an actual continuum of care for these folks.
That leads to the next question. So do you think that peer support and peer work could play a role in that? And what are you doing in Redfish to support peer work?
So we are developing a peer program at Redfish as we speak, because there's a lot of people who've graduated the program and who are doing really well. People like Ollie, for instance. So that is something that we're developing, and we're making a line item in the budget. But what can peer support do writ large? I think it's engaging folks where they are. So this is where we need to have a continuum of care where there is a group of people that can work on an outpatient basis and meet people where they are. We can't just build Redfishes and hospitalize our way out of this. We need to have community supports and treatment. And as Alex mentioned earlier, we need to have some sort of prevention, because I think there's been no focus on that.
I summarize a few questions here because of time, but so there is observation and kind of also disappointment that a lot of treatment agencies are extremely narrow and they're not providing good treatment opportunities like continuity management or like a family work and like peer work and so on and so forth. What do you think as a clinician overseeing the province for a while? What could we do to actually stimulate a broader treatment approach and a better integration of services?
I think the first thing we need to figure out is what is the need. So there was a recommendation from a paper from 2010 saying that we need to develop a database to figure out how many patients. We literally don't even know the number of patients and what the disorders are. So how do you even build a continuum of care if you don't even know what the need is and where is the need and how does this change from health authority to health authority or region to region? So first we need to figure out the data of what is the need, and then we need to look into communities and how do we engage people where they're at in the community. And we need to develop a system of complex housing where folks can be supported in terms of their mental health or physical disabilities along with their substance use in a place that's safe.
Mm-hmm. Nick, so unfortunately the time is done. Thank you very much for your very thoughtful perspectives and inspirational talk. There are lots of questions still open, and we have to excuse ourselves that we are unable to address all of them. So please really be courageous and bring up the topics in the breakout sessions too. And the next session is starting in a few minutes at 9:20. Thanks so much for joining us, Nick, and I hope to see you at other occasions very soon. And I'm really impressed by how much papers you're obviously reading in your scarce time between all the other duties you have to follow. Thanks so much. And I would recommend everybody now to find the right breakout session for your interest. And thanks so much for a very stimulating first session. Take care.
Thank you, Michael. Take care.